Welcome to my YouTube channel. Today we're going to talk about oculomotor nerve palsy. Oculomotor is cranial number 3. So oculomotor nerve palsy occurs when oculomotor is damaged, and this leads to eye movement abnormalities, ptosis, and pupillar dysfunction. So this is what you're going to talk about in this lecture. So the function of cranial number 3, it has two major functions, that is the somatic and the parasympathetic. The somatic or the motor function usually controls 2 out of 6 extraocular muscles, and the muscles that it controls include superior rectus, which moves the eye upwards, inferior rectus, which moves the eye downwards, middle rectus, which moves the eye inwards, inferior oblique, which moves the eye upwards and outwards. Meaning, if we have 4 muscles, 2 of the muscles are not supplied by oculomotor, and they are they are lateral rectus and superior oblique. Lateral rectus usually moves the eye outwards, and in superior oblique usually moves the eye downwards. So in oculomotor nerve palsy, you will have the eye moving outwards and downwards. So in addition to that, the motor function also controls the levator parabolus superficialis, which is involved in eye elevation. So this patient will present with ptosis, that is drooping of the eyelid. So the next function is parasympathetic, and it controls the pupil and the length. So in terms of the pupil, we have the sphincter pupillae muscle, which after stimulation by the parasympathetic, it causes pupil constriction, and that is miosis. Afterwards, in the lens, we have ciliary muscle. When it is stimulated by the parasympathetic, we have accommodation of near vision. If cranial 3 is damaged, both motor and parasympathetic function are usually affected. So let's briefly look at the subdivision or the classification of cranial nerve palsy. We can divide it as pupillary involving or pupillary sparing. The oculomotor is kind of divided into two, where we have the motor being inner and the pupillary or the parasympathetic being outer. So any involvement or any lesion affecting the outer, such as compression by either an aneurysm, a tumor, or annihilation, will result to the with disruption of the parasympathetic fibers, therefore meaning we cannot constrict the pupil. If the pupil cannot constrict, what will the pupil do? The pupil will dilate. However, when it comes to causes such as ischemia, which majorly involve the inner part of the oculomotor, will majorly result to the palsy of the extraocular muscle, while sparing the outer part, that is the pupillary fibers. So in this, will have pupil sparing oculomotor nerve palsy. So we've mentioned that we have pupillary involving versus pupillary sparing oculomotor nerve palsy. So the features, the causes, just say the first one, the pupil involving is usually majorly compressive, such in case of an aneurysm, a tumor, and ankle herniation. Whereas in pupil sparing cranial nerve 3, we usually have ischemia, small vessel disease, for example, in diabetes. So in pupillary, we say that the outer part of the oculomotor usually, sorry, the outer part of oculomotor is usually parasympathetic. So that if it is affected first, then you are going to have dilated pupil, that is a brown pupil. Whereas in pupillary sparing cranial number 3, you are going to have normal pupil because the parasympathetics are spared. The position of the eye, because in both the motor fibers are affected, you will have your eye being down and out, and also in pupillary sparing, having your eye being down and out. The most common cause of pupillary involving cranial number 3 palsy is usually posterior communicating artery aneurysm. This is a must know. So the posterior communicating artery aneurysm, when it compresses on the oculomotor, then you can develop pupillary involving cranial number 3 palsy. Whereas pupillary sparing cranial number 3, examples or causes is usually diabetes, hypertension, and vasculitis. The severity is usually for pupillary involving is usually urgent, and you may require a CT angiogram or MRI angiogram, and then because it is an aneurysm, while less pupillary sparing cranial number 3 is usually less urgent. The prognosis requires urgent intervention to prevent the rupture or herniation. Just look at the causes that we say. You see aneurysm, we say tumor or ankle herniation. Whereas the causes such as diabetes, vasculitis usually mostly self-limiting and usually recovers in weeks. The rule of thumb that a brown eye, that is caused maybe by aneurysm, as you have said, is usually urgent, and you need to get an urgent CT angiogram or an MRI angiogram. Whereas the pupillary sparing usually have normal pupil is usually because of diabetes. So the clinical features of cranial number 3 palsy usually have ptosis, as we said, because of the involvement of because of the paralysis of levator papal superficialis muscle, which is involved in the lid elevation. Ptosis is just drooping of the eyelid, as you can see in this picture. Down, eye down and out. The reason we said because down is because of the superior oblique and out is because of the lateral rectors. We can also have diplopia or double vision, and this is because due to misalignment of the eyes. We also said we can also have pupillary involvement, and this is if it is dilated, and this is mostly because of a compression. And we said the most common reason is because of the posterior communicating artery aneurysm. So key finding, if the pupillary is involved, you need urgent imaging and you need to do a CTA or CTA or MRA to rule out the aneurysm. So classical features of down out, as you have said, we are going to have this is because of the somatic fibers being affected. We're also going to have ptosis. This is the drooping of the eyelid due to the levator, eye out and eye down and out, diplopia and pupil involvement. So the diagnosis, clinical exam is very important. In the clinical exam, you're going to see ptosis, that is a drooping of the eyelid. You're also going to see the position of the eye, which will be down and out, and the pupillary size. So pupillary reaction in this, if it is a dilated pupil, then you get a CTA or an MRA to rule out posterior communicating aneurysm. Normal pupil is, we said, the most likely is because of ischemia, and the most causes usually diabetes or hypertension. So the neural imaging already said, that is MRI or MRA or CTA of head and neck if suspecting aneurysm or a tumor. Diabetes workup, you can do an HbA1c, fasting glucose, and if ischemic cause is usually suspected, meaning when you have a normal pupil. So the management of pupillary involving versus pupillary sparing cranial number 3 palsy. Pupil involvement, you see this one is compressive, and we said it's an emergency for you to rule out the posterior communicating aneurysm. So if it is an aneurysm, then you surgically repair the aneurysm either by clipping or coiling. If there's a tumor, you call the neuro team or you call the oncology team for referral. Pupillary sparing, that is mostly ischemic, and the cause usually diabetes and hypertension or vascularis. Of cranial number 3 palsy, you treat obviously the underlying cause, that is diabetes, hypertension, and vascularis. You can also do supportive care, that is patching one eye may help in diplopia, and this usually results in 6 to 8 weeks. So summary, we say that cranial nerve 3 palsy, you will have the eye down and the eye out, and this is because of superior oblique and lateral rectors. You also have going to have ptosis. This is because of the levator, and possibly you can also have a brown pupil. And when you have a brown pupil or a dilated pupil, it means that it is a compressive lesion and it is an emergency. So when it is pupillary involving, it's an aneurysm or a tumor or an ankle herniation, and this one is usually an emergency. If it is pupillary sparing, that means it is ischemic. That it means diabetes, hypertension, and usually self-limited. The diagnosis we mentioned, if it is pupillary dilated, you need an urgent CTA or an MRA to rule out aneurysm. If the pupil is normal, then you treat the underlying disease and check for its risk factors. Treatment of an aneurysm, we said this is neurosurgeon, and then if it is diabetic or ischemia, you do supportive and usually result